three-part WHO Health Workforce Action Series on health workers and COVID-19 under the theme, Protect, Invest Together. Episode 1 will focus on the important topic of protect. In this episode, we will share the insights of a panel of 3 esteemed speakers who will share their learnings thus far. Episodes 2 and 3 will be held in June and July, and we'll announce those in due course. This webinar will be recorded, and presentation and learning materials along with the event recording will be sent to you within 10 working days after the event. We will be also sharing a brief survey during the webinar. We hope that you will respond. All responses will be anonymized. You all have been muted and your cameras turned off with the exception of panelists. Please ask questions using the Q&A function. If you have any technical issues, please use the chat. Don't be shy about asking your questions. If you ask a question early, it has a better chance of being shared with our panelists. The format of this session will be 3 panelists briefly presenting in about 15-minute segments, followed by question and answer. But to begin, I would like to introduce to you the director of the WHO Health Workforce, Jim Campbell, who will set the scene for us. Jim, over to you.
Thank you very much, Catherine. Good morning, good afternoon, good evening, wherever you are joining us from. Part 1 of a series looking at the key theme of protect. And I'm just going to do a very brief overview, scene setting with a few slides, just to, as much as anything else, to provide you a reference set of materials which will be available after today's event for access and download. It is 2021, the International Year of Health and Care Workers. This resulted from a decision in the resumed World Health Assembly in November 2020. And it recognized the dedication, the efforts at the forefront of the COVID response around the world from all health and care workers. But we know that there has been a major impact on health and care workers as they go about their job. And we've published in the weekly epidemiological update an overview of the impacts that we see both on the health and well-being of the health and care workforce, but also on some of the systems issues that come through and their working conditions. Many of these issues, infections and deaths, have hit the headlines, but we also see considerable challenge around mental health, burnout, stress, and anxiety. And we've seen record numbers of labor disputes, strikes, and protests in regard to the working conditions due to the hours that are being worked, the conditions of service, et cetera, et cetera. Next slide. We are continuously updating and triangulating our data and the strategic intelligence of the impact so we can inform the policy options resulting from this. And again, this is on the WHO website and the weekly epidemiological update. On the issue of infections, which has received considerable attention, our thanks to all member states that are continuously updating and submitting data that helps us build a public good, which we can then ensure that we can respond to. We saw at the very first stages over 12 months ago, high rates of infection as we battled with the first cases, personal protective equipment and protocol, clinical governance and protocol, maybe not ready to respond in perfect conditions. But that throughout the year, we saw a very, very strong public health and social measures kicking in, where the infection rate amongst health and care workers came down close to that observed in the general population. So the relative risk decreasing over time. Nonetheless, every infection and every death is a concern. What we build a picture then of in terms of the impact is that prior to COVID-19, the world was already experiencing a shortage of the workforce. If you have a glass half full or glass half empty analogy, there was a shortage there that had to be addressed. The ongoing COVID-19 response took many of that workforce and redeployed them for the emergency phases. We then saw increasing rates of infections and deaths, taking further capacity out of the system. And if we look to the third column here in the yellow, we then are asking, does this depleted workforce, this workforce that is already under considerable stress and exhausted from the last 15 months, to now be part of the world's largest ever vaccination program as vaccines are rolled out around the world. And this is a far cry from the reality of what is needed, the column in right, if we are to pursue the Sustainable Development Goals, the universal health coverage, and having capacity for emergency preparedness and response. All of this comes together in terms of the impact into a guidance document that was issued by WHO, looking at the work environment, looking at the opportunity to increase capacity and address the shortages. And that was issued in December of last year in an updated version. And the first theme is indeed, as you see in the top left, dark blue here, the first theme is the protection, including the obvious protection from infection, the adequate personal protective equipment, but also the broader protection, the decent work conditions, the mental health and psychosocial support, and some of the more broader occupational health issues to ensure that there are mechanisms in place for recognizing absence from work due to occupational COVID-19 acquired infections. Next slide. The same protect theme is in the international year and the theme for today's discussion. And we have that coming through to make sure that health workers are prioritized for the vaccine so that they are in a position to protect us, that we recognize those and commemorate those who've lost their lives in the pandemic, but we take action. We take action to ensure that there are commitments to act, that there are commitments to ensure that we have a care compact around protecting the rights, the work conditions, and the practice environments that our health and care workers practice in, and to drive solidarity in our actions for advocacy on this issue. Next slide. The same protect theme is in the work this year announced by France with WHO and Women in Global Health to protect the women in the workforce. As we know, globally, almost 70% of our workforce are female. And we need to ensure that they are protected from violence, from harassment, particularly sexual harassment in the workplace, that they are protected with pay equity for their work, and that, again, their work conditions are ensured consistent with the international year. So the protect theme, very, very relevant to the world's conversation at the moment. Next. The International Year, an opportunity for everybody to get involved and get engaged in the work. It came through the decision of the Assembly. Here's the URL links to the website. Download the materials, download the video. If you are a social media person, take the Twitter, the Facebook, the Instagram materials, put your messages out, campaign with us to ensure that we protect healthcare workers, invest in them, and that we can do so together in a very coherent manner. Thank you very much, Catherine. Back to you.
Thank you, Jim, for that compelling introduction. I'm Catherine Kane. I have the great pleasure of being your host today. If you're sharing with us on Twitter, please use the hashtag #SupportHealthCareWorkers. And I have the great pleasure of introducing to you our first panelist. This is Mr. Sanjay Tinley. He is the Chief Human Resources Officer of the Ministry of Health in Bhutan. Mr. Tinley brings over 30 years of experience to the fore and was responsible for deploying health workers at the beginning and during the response in Bhutan. I think we can tell a great deal about the decent work and about having sufficient members of the team from Mr. Tinley's words. Over to you.
Oh, thank you, Catherine, for the wonderful introduction on myself. So, good morning to all. This is Sanjay. You can call me Sanjay. Of course, my name is Sanjay Tinley. As Catherine said, yes, I have been working in the HR for last 30 years. However, I have joined the Ministry of Health in 2019, just more than 1 year ago. So I'm sharing a brief presentation prepared by the HR division, sharing the experience, HRH experience in the management of ongoing COVID-19 pandemic in Bhutan in terms of human resources. Next. So my short outline is I will share the background of Bhutan and some key strategies for COVID, and then go to challenges and lesson learned from this pandemic. So if I could just briefly introduce Bhutan, and I think the panelists who must be knowing, but still then Bhutan, I would like to say that Bhutan is a small and mountainous country with just 700,000 of population, and with a small population, we have small health workforce. So we have about 370 doctors and 1,500 nurses, and then about 1,000 technicians and 700 health assistants. And as of this information is as of December 31st, 2020, because the information keeps on changing. Every month people retired, every month then newcomers come in. So this I based for December 31st information. So in terms of health facilities, we have about 50 hospitals, that is 10 bedded and above, and about 186 primary health care centers. In the past, it used to be called basic health units. Now we have renamed as primary health care centers, and about 60 community health centers that is located in the villages or the communities. And also we have about 500 plus outreach centers. This composing of this health workforce. So in order to strategize the deployment of health workers, we have used the clustering approach of such capacity, which was prepared and adopted during the preparedness of COVID in early 2020, say in March 2020. So continue my background. Of course, we are lucky that not much of death cases, and we had only one COVID-19 case that also not originated from Bhutan, but it came imported from I think the it came from India. I heard not it is from the tourists came from India. So only one case that was in March 2020. Then since then we had about two nationwide lockdowns imposed by the government after March. So as on May 3rd, if I share some data on the COVID cases, so we have about 1,119 confirmed cases, and right now 119 active cases, and we recovered information is about 900, almost 1,000. So for kind information of the panel, as I said, there's only one death case, and that is from the not from the health workers, it is from the general public. So we are again lucky that we do not have any infection or death cases of health workers. And this was, I think this information was recorded by Catherine. So I'm sharing that out of the almost 4,000 health workers, the ratio or the female gender is now 54 are male and 46 female health workers we have. Then this is the now what we have adopted some strategies for COVID-19 is now. So we have very clear policy directives from the government, and that is called the leadership from the government or right from the throne. We have very political commitments and effort to prevent measures such as we have about such as like social engagement and initiative and strong solidarity and compliance around the preventive measures, such as mask wearing is is mandatory in Bhutan, and also like hand washing, hygienic etiquettes, and lockdown and quarantine protocols are strictly followed in Bhutan. So the other point is huge. The government has spent had huge investment on the public health system, such as robust surveillance system and aggressive testing, like 3Ts, like tracing, treating, and treatment. These three are strongly implemented. And other investment we did is now there's from right from the throne. I think there's a livelihood compensation to the general public in terms of monetary relief schemes introduced to business entities such as waiver of a loan interest and people affected by the pandemic. So there are huge investment from the government. Next. So other strategies we adopted are the HR backup team mobilized by small. We have, as I said, we had about 370 plus doctors, and now that number is not enough. So the government had to recall the postgraduate medical students pursuing their long-term studies abroad. If I provide the specific number, I think 50 long-term residents were called back for the preparedness of the COVID-19, and not only that, we have also used the services of retired doctors and nurses, and we also involved students from the universities and private diagnostic centers, and beyond that, we also went for the unemployed youths who were not employed. So of course, there's some investment had to be done, like payment of daily allowances. So these are the some of the strategies adopted by the Ministry of Health or the government of Bhutan. And yes, giving timely training of health workers for COVID-19 case management and surveillance and contact tracing, quarantine management, and these are some of the strategies adopted. And also deployment of health workers from the health facilities from green zone to red health facilities to the red zone area. Like as I said in the introduction, we have about 3 COVID zones identified, and then we had to deploy the nurses or the health workers from the green zone to the red zone areas. Then we also train of 300 volunteers. I think you must have seen some pictures that orange uniformed volunteers recruited by the government. They really served us, help us to function as a nurse during the emergency times. Like of course we had to train them, but these 300 plus volunteers really help us, help the Ministry of Health. Next. Then one of the strategies was formation of dedicated team for COVID-19 routine healthcare to ensure efficient COVID-19 response and seamless delivery of essential service. So teams were adequately trained and in person, or not through online, but we are trained by the only university, the health university in Thimphu or in Bhutan. So their service were fully utilized. Like we have a college, faculty of nursing and public health. So we use this. They use them for training, giving training for the all these there's the volunteers and also for the unemployed youths, as well as from the private clinics. So some these are the main I think main strategies applied. And also we have developed SOPs and guidelines for case management protocols and dissemination of the COVID protocols. And we also conducted simulation exercises prior to COVID-19 cases in the country. And other one is protection and infection prevention control on health workers, strictly monitored and supervised. Next. So the next is some of the challenges faced by the Ministry of Health, HRD. So now, because of the limited trained health professionals, we had to hire from the, not in fact, of course, there were volunteers from the private diagnostic centers. And we had to retrain them. And as I said, we employed the unemployed health workers. So we had to give them trainings. So if we had trained or professionals, we don't have spent a lot of expenditures on this area. So one of the challenges, of course, the main challenges we face is resource constraints, lack of funds. Like when we deploy our health professionals from one hospital, from low risk to high risk, and it involves transportation, traveling, and also daily allowances will have to be borne by the ministry. So in such case, we had some difficulties in mobilizing funds, but we were fortunate and we are lucky that the WHO country office Bhutan extended a great support to the Ministry of Health by providing all this funding for the to meet the expenses on the travel and transportation, and also meeting the daily allowances, because people have to move one place to another. So in such cases, we really need a huge funds. So we are always grateful to the WHO. In fact, WHO in general, and in particular the country of WHO country office in Bhutan. So we always approach them in case if a government not able to mobilize funds. See, the other problem is this pandemic is evolving rapidly. So there's not much of time given. So preparation time is really we had to. This is the main challenges, and so it's difficult to provide the manpower or the health professionals as and when required. So HR division is always asked to provide as soon as some outbreak, COVID outbreak is erupted in the districts. So immediately we are informed to deploy the health professionals. So this rapidly evolving pandemic situation really gave us no time to prepare for providing good trained health professionals. So short span of timing for plant adaptation is and education, as I said now, is really had a tough time for particularly the HR division, because the manpower we have is very limited, and we are not. The population is very small, so had a very difficult time in brief. Next. So this some of the lesson learned from this pandemic is now yes, there was a strong solidarity and IPC compliance workforce. So in the future, we have to really prepare for the infection prevention and control. Then we need to invest in emergency preparedness, including the resource mapping. Of course, in the first COVID outbreak, that this was really a challenge for us, and not much of capacity mechanism and deployment. We didn't have proper deployment plan, but from the second lockdown, we were much comfortable, and we were able to we able to have a good plan. Then we need for constant mentoring and supervision, monitoring at all level, because now from word girl to from the doctor, I think we need a proper supervision and monitoring system, but that we didn't have. So now we have to have a constant this system developed for the mentoring as well as supervision and monitoring. There was no proper counseling as well, and motivation is essential now, particularly for the frontline workers. There was no system for the motivation, and again, we had a tough time, but now to get the people to work in the front. So these are some of the strong lesson we have learned. Then we also need to maintain a database for private health professionals. This is a lesson for the ministry, not only for HRD. Now we have to have a database developed for the private health professionals working in the diagnostic kind of like from nurses to doctors, from technician. So we are now asked to develop a database. So we hope we can we are able to now to develop a strong database for the for the private and health professionals within and outside the country. Yes. Oh, that's finished. Thank you so much, and hope if you have any queries, and let me try to answer. But in case if I'm not able to provide the response, so I will keep the note and then provide through email or in consultation with my colleagues in the HR division or the management, the Minister of Health. So this is what this is just short presentation from the HR division, Minister of Health, Royal Government of Bhutan. Thank you so much.
Mr. Thinley, thank you so much for keeping to time, very impressive, and for bringing lessons from a small mountainous country where time to travel somewhere is measured in days and unusual forms of transportation. I think some of the strings that you're bringing together with regard to ensuring adequate numbers of health workers, ensuring that they're trained, ensuring that they're aware of IPC practices and that protocols are available to guide their work in addition to supervision. These lessons are really important. You've brought in some really interesting areas with regard to counting your health workers and having databases. You value what you can count. Thank you so much for sharing your lessons. I see that we've already got a question in the question box. I take this opportunity to remind people that I send Swiss chocolates for questions. So just in case you're wondering, now is the time for questions. I also will draw your attention to the bottom right corner, wherein we have interpretation. We have interpretation available in Russian, French, Spanish, Portuguese, and Arabic. I now have the great honor of presenting to you someone who will draw the thread forward from Mr. Thinley's note on counseling. Dr. Anissa Boasker is the president of the Psychological Assistance Cell for Victims of Disaster in Tunisia. She will share the experience of drawing together a number of mental health professionals to support health workers during this challenging time. Dr. Boasker, to you. And if we can just ask you to unmute your microphone, we look forward to seeing your presentation.
Bonjour. Bonjour tout le monde, merci beaucoup pour votre invitation. J'ai écouté avec beaucoup d'intérêt les précédentes présentations. À mon tour maintenant de partager avec vous l'expérience tunisienne. Tout d'abord, je vais commencer par me présenter. Donc, je suis Dr. Anissa Boasker, je suis psychiatre et psychothérapeute. J'étais psychiatre hospitalo-universitaire à la faculté de médecine de Tunis et à l'hôpital psychiatrique. Et depuis 2 ans, je suis en exercice privé, mais je reste à la disposition du ministère de la Santé dans le cadre des interventions de crise. Au sein donc de la CAP, cellule d'assistance psychologique des victimes de catastrophes, qui relève du shock room et qui s'active à chaque fois qu'il y a des crises dans le pays. Donc, je vais essayer de résumer en 15 minutes ce que la cellule d'assistance psychologique a entrepris au moment de la pandémie Covid-19, en particulier auprès de personnels de la santé. Puisque la CAP intervient en général auprès des victimes de catastrophes, mais comme c'est une crise qui dure dans le temps, au début, on s'est focalisé sur les personnes qui étaient dans une période au moment du lockdown, et en même temps, on a aussi suivi les besoins des personnels de santé quand ils étaient en crise. Donc, dans cette présentation, je vais commencer par parler de l'état du personnel de la santé, parce que nous nous sommes aussi intéressés, même avant la crise, à l'état de santé mentale du personnel de la santé, parler de principaux défis pendant cette crise et les interventions qu'on a faites dans le cadre de la CAP, avec quelques résultats, les leçons retenues et les recommandations pour le futur. Rapidement, pour la cellule d'assistance psychologique qui travaille depuis 2015 de manière informelle. C'est un groupe c'était jusqu'en 2016 où il y a eu un arrêté ministériel pour la création de cette cellule. C'est une unité fonctionnelle, c'est une cellule dormante qui s'active quand il y a un désastre, et elle est formée de psychiatres et de psychologues et qui sont bénévoles et qui, la plupart, ils sont dans le secteur public et qui sont réquisitionnés au moment des crises pour intervenir auprès des victimes. Alors, quand il y a eu la Covid, on n'a pas accès, et surtout quand il y a eu le lockdown et les personnes étaient coincées chez elles et ne pouvaient pas avoir accès, elles étaient parfois en situation de détresse psychologique, elles ne pouvaient pas consulter, et donc on a mis en place, grâce à un appel aux professionnels de la santé mentale pour intervenir à distance. Vous pouvez trouver dans cet article comment on s'est organisé. Il y a eu, comme vous voyez sur la photo, une petite formation pour des volontaires. C'était des étudiants de médecine qui ont été et des bénévoles du Croissant-Rouge. Ils ont été formés rapidement pour être des téléopérateurs, pour faire le triage des appels des personnes en détresse et les adresser vers des psychiatres et des psychologues qui pouvaient prendre les appels en temps réel. Ça, c'était pendant la première vague, c'était pendant le lockdown, mais en parallèle, on a mis deux numéros pour le personnel de la santé et on a fait appel à une ONG qui, moi aussi je suis dans une autre ONG qui s'occupe en principe des réhabilitations des survivants de la torture, mais aussi qui s'occupe aussi des personnes qui sont impliquées dans l'humanitaire. Et en même temps, donc, on a adressé à cette ONG qui s'appelle Epidemiological, les personnels de la santé de la première vague qui avaient besoin d'une prise en charge psychologique. Et je vais tout à l'heure vous parler des résultats de ce travail pendant la première vague et de l'évolution des besoins pour la deuxième et la troisième vague. Avant la COVID-19, je vais présenter rapidement, juste pour dire qu'il y a eu des travaux qui ont concerné le personnel soignant, et ces travaux ont déjà, même dans la crise de la pandémie, disent que le personnel soignant est en difficulté, qu'il y a une grande prévalence du burn-out. Ici, par exemple, en 2014, on donne un chiffre de 70% dans une unité qui prend en charge des personnes en fin de vie. Un autre travail en 2018 dans un service de réanimation conclut à grande prévalence de 72% de burn-out chez le personnel, le staff dans le service d'anesthésie réanimation, et un travail qu'on a mené avec, moi j'ai encadré un mémoire dans le cadre d'un diplôme universitaire de victimologie qui concernait les intervenants de première ligne dans 4 services hospitalo-universitaires des urgences, des différents hôpitaux de la capitale et un service de SAMU, et qui trouvent que 81% du professionnel, c'était des médecins et aussi des paramédicaux. Il y a eu 60 répondants, et on a trouvé que 80% souffraient d'épuisement professionnel, que l'usure de compassion, ce qu'on appelle fatigue de compassion, était très importante, et surtout aussi grâce au test de Maslach-Burns burnout inventory, on a trouvé que 48% parmi les soignants, les intervenants en première ligne avaient un taux élevé de dépersonnalisation, c'est-à-dire c'est un symptôme qui signe le travail porté sur le traumatisme vicariant. Donc, on a aussi développe des symptômes traumatiques quand on intervient dans des services où on intervient auprès de personnes qui se trouvent dans des situations de détresse vitale. Quant à la prévalence de l'accomplissement, sensation de l'accomplissement personnel, elle était aussi faible dans une grande proportion du personnel. Tout cela pour dire que déjà avant la pandémie, nous avions un personnel soignant épuisé qui était en souffrance. La conscience des responsables est différente selon les hôpitaux. Il y a des hôpitaux qui déjà qui sont mieux organisés que d'autres dans la prise en charge, dans l'accompagnement psychologique du personnel, comme l'hôpital de Charles-Nicolle. Et puis, il y en a d'autres où ça n'existe pas, cette mentalité n'existe pas encore. Il y a un grand travail de sensibilisation à faire. Alors, revenons aux circonstances actuelles de la Covid. Alors, il y a deux choses. On est dans autant la première vague s'est relativement bien passée, autant qu'il y a eu cette mobilisation qui était, et il y a eu le lockdown, il y a eu une maîtrise de la pandémie, autant en ce moment, on est dans une phase très, très difficile où on a une centaine de décès par jour. Vous avez des chiffres ici avec plus de 10 868 décès depuis le début de la pandémie. Alors, et avec en même temps une vaccination qui est très lente. On est à 8% de la population vaccinée, à 0,8% au jour d'aujourd'hui. Et même parmi le personnel soignant, il y a des personnes qui ont déjà attrapé la Covid, 1 ou 2 fois même, et il y en a d'autres qui sont au jour d'aujourd'hui encore réticents pour aller se faire vacciner. Selon l'OMS, il y a 14% du personnel qui a été touché et qui peut arriver jusqu'à 35%. Ici, ça dépend des hôpitaux. Je n'ai pas de chiffre général, mais j'ai essayé de faire une enquête auprès des hôpitaux. Un des grands hôpitaux de Tunis, la Rapta, donc j'ai trouvé 605 cas de Covid donc, sur 2500. Je voulais aussi chercher quelques indicateurs par rapport à la santé mentale, et je trouve que les congés de maladie de longue durée, pour nous, il y a deux demandes de congés de maladie, des arrêts maladie pour cause de dépression ou d'épuisement, ils sont en hausse d'une année en année. J'ai aussi trouvé une publication récente d'un travail qui a été fait dans un hôpital régional dans le nord de la Tunisie et qui trouve que c'est une enquête qui a été menée auprès du personnel et qui trouve que publiée en mars 2021, et qui trouve que 14% du personnel a été contaminé, et c'est surtout les infirmiers suivis par les résidents. Mais dans cet article, on se préoccupe du manque de dispositions de prévention suffisantes. Et ça m'a été rapporté aussi par certains chefs de service qui qui sont dans les premières lignes, qui travaillent beaucoup sur le Covid, l'état d'épuisement du personnel, du burn-out. On arrive à observer des comportements à risque où le personnel, ou par fatigue ou par lassitude, ne prend pas des précautions suffisantes et peut même s'exposer au danger. Voilà le contexte général qui n'est pas très gai. Plus il y a des problèmes depuis le contexte particulier de la Tunisie, depuis 2011, on est on va dire en transition démocratique, mais c'est une bonne chose, mais en même temps on a une instabilité politique avec des changements trop fréquents au niveau du ministère. On a eu plus que 11, on ne les compte plus depuis 2011. Donc, la durée de vie d'un ministre est inférieure à 1 an. Il y a toujours des changements. Il n'y a pas beaucoup de stabilité politique, même au niveau de du commandement. Donc, il faut s'adapter à chaque fois. Il faut faire preuve de souplesse. Bon, les équipes, elles restent les mêmes, mais c'est les commandements qui changent. Il y a la lenteur donc, de la vaccination. Donc, on se sent moins protégé, même en tant que professionnel. Il y a cet épuisement. Comme vous l'avez si bien dit dans la première présentation, il y a le professionnel, il est épuisé, mais plus que l'épuisement, il y a aussi un manque de reconnaissance. Il y a aussi il n'y a pas de valorisation suffisante par rapport au travail du professionnel. Je peux vous rapporter même ce sentiment qu'on trouve chez le professionnel. On sent on se donne, on se sacrifie, il y a un sentiment de stigmatisation. Nos familles aussi sont exposées. On a eu, par exemple, dans un seul hôpital, donc 4 personnels paramédicaux ont eu leurs parents contaminés et 3 sont décédés. Imaginez ces personnels, comment ils vont travailler avec cette culpabilité d'avoir ramené la maladie à la maison. Donc, vraiment, il y a beaucoup de problèmes par rapport à la Covid. Et déjà, l'État était fragile, mais là, avec la Covid, c'est réellement une crise. C'est pour ça que la CAP intervient en particulier. Donc, voilà, notre démarche, elle est beaucoup plus préventive. On va aller proposer de l'aide aux personnes qui sont vulnérables. Il y en a beaucoup qui sont déjà même suivies en psychiatrie et essayer d'intervenir pour renforcer la résilience chez ces personnes fortement exposées. Et on a proposé, il y a eu donc le ministère est conscient de ce problème. Il a invité beaucoup d'intervenants au niveau de santé mentale et nous, au niveau de la CAP, on a proposé une création d'antennes au niveau de tous les hôpitaux et ces antennes doivent être composées d'un psychiatre, psychologue et aussi d'un médecin de travail parce qu'il faut la médecine de travail pour adapter le poste de travail, les conditions de travail et parce que le psychiatre, psychologue ne peut pas faire grand-chose tout seul si les conditions générales ne changent pas. Il y a aussi un autre problème, les résidents de psychiatrie qui étaient plus volontaires avec nous pour la première vague, sont au jour d'aujourd'hui aussi réquisitionnés pour faire des gardes Covid. Donc, eux-mêmes, ils vivent ce stress-là, eux-mêmes, ils ne sont pas beaucoup disponibles. Excusez-moi, combien de temps il me reste, parce que j'ai tendance à un peu m'étaler.
Pas beaucoup.
Pas beaucoup. Alors, 2 mots sur les interventions. Alors, première vague, je vous ai dit, on a fait cette affiche en collaboration avec le Nebras et on a mis à la disposition, on a été appelé. Donc, je vais aller donner les résultats de la première vague. Voilà, ceux qui ont demandé de l'aide, c'est beaucoup plus les paramédicaux, et avec une prédominance évidemment féminine, puisque le corps soignant est beaucoup plus féminisé, que ce soit au niveau du paramédical ou du médical. il y a plus de femmes, et aussi parce que les femmes ont beaucoup plus de charges. Des fois, on trouve, c'est surtout, elles sont des mamans, des enfants en bas âge, des fois, on trouve aussi des parents à charge, etc. Et c'est les femmes qui sont plus impliquées. Ils ont quand même des antécédents psychiatriques préexistants, comme j'ai dit, il y a cette fatigue ancienne et donc c'est beaucoup plus des paramédicaux parce qu'il y a comme une sorte de, on va dire, de tabou chez les médecins de aller vers une structure, ils viennent plus dans l'informel, ils nous contactent, mais de manière un peu anonyme, enfin anonyme, pas anonyme, mais pas dans un circuit officiel pour qu'on les aide, etc. Donc, c'est beaucoup plus des troubles anxieux, mais il y a des troubles dépressifs, il y a beaucoup d'angoisse et des problèmes de sommeil. Pour la troisième vague, donc la troisième vague, elle coïncide avec la création du centre d'appel qui a été créé grâce à l'appui de l'OMS. On a mis en place notre propre centre d'appel suite à la réussite de l'expérience de la première vague. Et là, on a recruté des psychologues, des téléopérateurs qui étaient c'est aussi des bénévoles, mais ils sont en stage, on va dire, pour leur master. Et le problème ici, qu'on a pu, donc ils ont fait plus que vers 359 appels. Ils ont appelé des soignants qui ont été proposés par le ministère et 73 parmi ces appelants ont formulé des demandes d'aide psychologique, mais le problème, on n'a pas de psychiatres et psychologues assez qui sont disponibles, et ça, on n'a pas beaucoup de ressources, on ne peut pas compter éternellement sur le bénévolat, on doit s'organiser avec les chefs de service pour libérer, par exemple, des résidents pour qu'ils puissent participer. Alors, les leçons retenues et les recommandations, alors voilà, les personnes soignantes a d'énormes souffrances. Il faut reconnaître ces souffrances. Le personnel nous dit, on a l'impression que les autres, quand ils voient comment la population ne respecte pas les mesures de protection et quand ils sont submergés dans les urgences, ils sentent cela comme une agression par rapport à eux. Il y a le côté genre, et ça a été dit dans la première présentation, oui, j'appuie, et les femmes sont beaucoup plus concernées et elles, comme j'ai dit tout à l'heure, elles se trouvent aussi, il faut les aider, il faut leur présenter une aide adéquate pour elles, introduire la culture de la gestion des stress, comme on a commencé dans cette situation de manque, on a décidé d'aller vers les postes les plus exposés et de leur faire des interventions de groupe et leur apprendre, donner des outils pour la gestion de stress, et ceux qui sont vraiment en grande difficulté, leur proposer des prises en charge individuelles. Donc, la CAP, elle est débordée, elle essaie de faire répondre à l'urgence, mais il faut mettre en place une structure qui va spécifiquement s'occuper du bien-être et de la prise en charge psychologique du personnel. Pour conclure, donc voilà, la santé mentale des soignants et leur bien-être doivent être une priorité. Si on ne prend pas soin des soignants, ça va avoir des répercussions, que ce soit sur donc les soignants eux-mêmes et leur intervention. Ils ne peuvent pas s'occuper des autres si eux-mêmes ils ne sont pas bien pris en charge. Donc, il faut investir en ressources humaines, en formation, mobiliser des équipes multidisciplinaires. Le psychiatre, le psychologue seul ne peut pas faire grand-chose. Il faut le médecin de travail, il faut des mesures sociales importantes pour aider nous on dit une armée blanche pour accomplir ce travail dans ces situations. On est dans une guerre, hein. Ici, on est dans une guerre. Et je vous remercie pour votre attention.
Merci mille fois, Dr. Bouaskar. You have demonstrated one really interesting element of good health and good mental health, which is exercise. I think you gave our translators a very good workout with your speed and also with your passion. Thank you for drawing out some very important points with regard to the workforce gap, including in mental health personnel, and the use of students who were mentored to work in mental health and provide services to health workers for the immense stress, the immense burnout, the immense demands that they are encountering during COVID-19. One of the elements that you really highlighted was the whole of society response. It's not just public sector resources, but it is the NGOs. It is the whole of society that needs to mobilize to end COVID-19. And I think that the work that your organization is doing is really demonstrating a number of different issues, especially within mental health resources, and the need, and thank you for mentioning this at the end, the need to invest in health workers. We'll be continuing that in episode 2, but for now, I'd like to turn the floor to Mr. Baba Ai. He is the Health and Social Sector Officer for Public Services International, which represents 30 million public sector workers, of whom 14 million are in the health and social sector in 155 countries worldwide. We've talked about decent work, and we've talked about mental health resources, and we've talked about having sufficient numbers of well-trained and supervised health workers. Baba, looking forward to hearing your insights, sir.
Thank you very much. It's a pleasure, Catherine, and thanks to WHO for this webinar and for 2021 as the International Year of the Health and Care Worker. There are two things I would want us to have in mind as I make this presentation. First is Arundhati Roy's position that the pandemic is a portal. As Jim pointed out, for example, Jim Campbell, there have been issues of which workforce shortage was a major one, even before the pandemic. The pandemic highlighted this and exacerbated this. And for us to come out on the other side with a better world, we need to take far-reaching steps. The second thing is there are linkages. I mean, the 3 pillars of the year, protect, invest together, I mean, are all interlinked. And I think having protect as the point of departure is excellent, because we need to invest in protection and we need to work together to properly protect. A second linkage is that between health and society as a whole. The protecting health workers requires looking broadly at a number of issues, including including the political economy. For example, when we had the shortages of PPEs, these had to do with global supply chains, and also the issue of science. I mean, if we look at Houghton and Deborah Mackenzie's books last year, and which I had the pleasure of reviewing both, you see how, to a great extent, there are questionable issues which would, not in terms of the science itself, but in terms of how it's related to health in ways that could protect or did not adequately ensure protection of health workers. So starting with the decent work and its 4 pillars, the 4 pillars being job creation, this focusing more on availability of work and workers not being barred from this. In the health sector, it's even that you have great vacancies, even though you also still have unemployment in the sector. The issue of rights at work, this has to do with working time. This has to do with ensuring that workers have living wages and there's non-discrimination. The issue of social protection, which is where workplace safety and occupational health takes a central place. I mean, including also free time and rest, which are essential for mental health, amongst other things, and the need for workers to have access to benefits. Then social dialogue. Social dialogue is critical for workers to have a say in how their workplace is run. And the primary ones, I mean, right to organize, right to collective bargaining, and right to decent work. Relating the decent work agenda to the health and care sector, I'll say a point of departure, as I pointed out earlier, drawing from Jim Campbell's, is a major obstacle to providing safe and effective staffing for health. 4 years before the pandemic, in fact, 5 years starting from the global workforce strategy 2030 of the WHO, and then through the United Nations High-Level Commission for Health, Employment, and Economic Growth in 2016. And then in 2017, the WHO's Working for Health 5-year action plan. It's been established that we had a shortage of not less than we would have a shortage of not less than 18 million health and care workers by 2030. But concrete steps were not taken to address this by most countries. And this contributed significantly to workers being overstretched during the pandemic. But even before the pandemic, we must remember there had been increased incidents of doctor suicide, nurse suicide in a number of countries, including in North America. But this is not the only expression of the debilitating situation that health workers find themselves in. Then you also see that it's not only that we don't have enough health and care workers. Health and care workers work in increasingly precarious circumstances. Non-standard forms of employment have been on the increase in the past couple of decades, but particularly so since the global economic crisis in the first decade of the century. And this has very, very severe consequences on mental health, on healthcare delivery itself, and so you can see that without job security for a number of workers, it's actually amazing the extent to which health workers as front lines did fight to push back SARS-CoV-2. Apart from being inadequate, apart from working in unsafe, apart from working in precarious conditions, health workers are also largely underpaid. Since the beginning of the century, you have seen a secular reduction in the proportions of wages of health workers in the broader health expenditure. We have seen wage freezes. We have seen, ceilings on promotions based on fiscal consolidation measures. And some of these also flow from conditionalities by international financial institutions to countries, especially where and when these have to draw loan facilities. The issue of migration, we appreciate the fact that migration is a fundamental right, sort of. In a sense, we are all migrants, really. But it is important to also note that a major push factor why health and social care workers leave countries, particularly countries even in more dire need of these health and social care workers, is lack of adequate remuneration and lack of decent working conditions. And then thirdly and lastly here, the issue of social dialogue. We'll talk more on this later, but just to point out here, Jim also mentioned the issue of widespread strikes. There have been strikes in at least 84 countries since the pandemic started. And it is important to know that even before the pandemic and during the pandemic, most of these strikes have been based on what in employment relations you describe as dispute of right and not dispute of interest. That is to say, they were strikes that emerged to get what had been won earlier. They were not necessarily calling for new they were not based mainly on new demands. These include collective agreements not being respected, and international labor standards not being applied. And we have faced repression. Health workers have faced repression in several countries. In Zimbabwe, our members are still, being charged to courts for demanding adequate personal protective equipment provision. So that is just an example of. But social dialogue, So anyway, relating this more concretely to the issue of occupational safety and health in the sector. I mean, the health sector is probably where you have the entire gamut of physical, biological, chemical, economic, and psychosocial hazards being quite prominent. And we saw this further we've seen this whenever you've had epidemics in terms of biological exposure, and with the work nature, we've seen the impacts of economic and psychosocial risk increasing, impacting on mental health, impacting on physical wellness and well-being of the health workers in general. And often on the expressed aspect of occupational safety and health is the gender dimension, and I was very happy to see this was, it was part of what we're to look at. It starts even from the issue of policy formulation. There's a seemingly gender neutral approach to this, and generally in occupational safety and health, this is something to be done away with. But it is even particularly so in the health and social care sector, where some 3/4 of the workers are women. And in design, in some PPEs, personal protective equipments are designed without necessarily having the gender dimension in view. Another aspect of this, because the issue of lack of gender equity also has to do, with power, and you see that whilst you have more women in the health sector, the concentration of women is higher in the lower rungs, and both in terms of different professions and even in terms of in the relationship between professions. And here, for example, you talk of community health workers. When the pandemic started and during the it's not as if it's totally over, but it was at the early points. I remember the PSI General Secretary Rosa Pavanelli had to write to the Director General, Dr. Tedros, of the PSI, pointed that, look, this issue of the global shortage is itself an emergency within the global health emergency. And part of what we also pointed out then, in a number of countries and regions, South Africa, South Asia, our members that were community health workers, expressed the fact that, look, due to the shortage, what was available was being even managed, and despite the fact that they had to go out for things like contact tracing, they were left highly at risk. We do appreciate the fact that one of the recommendations of the WHO Infection Prevention and Control Guidance Development Group addressed this to some extent. And the impact of psychosocial hazards, we've seen, violence, it has also been on the increase, even before the pandemic. Between 2008 and 2010, for example, you had 159 healthcare workers killed, but by 2012 to 2014, these had skyrocketed to some 760, including killed, including maimed, including harassed in different ways. Now, I think one of the important, probably the most important thing we have to do here is to look at, okay, what is to be done? How do we move forward? What are the gaps to be addressed? First, we think there should be genuine commitment to meeting the workforce shortage. Countries made political statements of commitments to implementing the UN Commission for Health, Employment and Economic Growth recommendations in December 2016. They took a step forward in May 2017 for the Working for Health 5-year action plan resolution. We need to see action. We need to see action on this. The pandemic shows that we don't have the luxury of time. We don't have the luxury of going slow on this matter. It is central to addressing the lack of safe or the shortcomings of in terms of trying to get safe and effective health across the world. And it is not even just about employment, improving employment, but also decent work, the working conditions. The remuneration of health workers needs to be improved. I mean, we've had a lot of applause. We clap for our members, but I mean, you don't buy baguettes with claps. You don't pay your bills with claps. Workers need, health and care workers need to be better paid, and working conditions as well. Health sector should not be somewhere where you have precarious work being generalized, as is the case now. The work income security and job security needs to be put in place. There could be transitional means to this. A good example is from the old Brazil. I say old Brazil, well, anyway, yeah, I say old Brazil, where you had the National Inter-Institutional Committee on the Precarization of Work in the SUS, their health system, to address the complaints about increasing precarization. Then there's the need for enhanced social dialogue. We are very pleased with the Working for Health plan, because you had the point of departure, the first step in its trajectory for change was recognition of the need for concerted tripartite social dialogue. So this will be essential to addressing disputes, particularly disputes of rights, and the impact of this on the health system itself in general. But beyond that, to ensuring workers have a say directly. I would run to them. On occupational safety and health, there has to be a more inclusive approach in formulation of policies, in implementation, and this is to say that they should not only be bipartite, occupational safety and health committees, and so there should be women reps, there should be representatives also of sexual minorities, LGBTQ plus workers, at all levels of decision making in the formulation of occupational safety and health policies, and in taking this forward. Research and design for occupational safety and health needs to take into cognizance gender dimensions. The OSH policies also need to do this. Then, as I pointed out earlier, we can't avoid looking at the issue of the political economy. One of the key things we have learned from the pandemic should be the need to regig the global supply chain for the health and social care sector. The lack of PPEs at that critical moment reflected a major flaw, and the world must not put itself in that situation again. Information, communication, and training on workplace safety and occupational health needs to be given top priority at workplace level. Then at the national level, data, information, and planning.
Absolutely. Mr. Baba,
yeah, I'm about rounding up.
I know, and you're fabulous. So, but if we could ask that so we can get to just a few questions.
Okay. Just to sum up, the last bits I would have to say, skipping a couple of things, has to be about the science and evidence and how we apply this to the health sector in terms of protecting health and care workers. A major disputes, and which we as PSI, our affiliates, have raised right from January, has been that in a situation where we don't have full understanding of what we are fighting coming from the microbial world, there is the need to apply the precautionary principle. I mean, this debate on airborne, not airborne spectrum, it is essential, because the thing is, by the time it is very clear with evidence that it is airborne, so to speak, and because we're also drawing lessons, not only this pandemic has happened, we are still in it, we will get out of it. But for subsequent times, it is that by the time it is clearly established beyond any doubt, so to speak, lives are lost. Lives of health and care workers are already lost. We can't bring back those workers. So I will sum up here that, look, we should draw from the inspiration and wisdom of Goethe when he said, all theory is gray, my friend, but forever green is the tree of life. The blood that have been shed, the blood of health and care workers as well as others in this pandemic should not be in vain. We have to draw the correct lessons and come out with a better and healthier world at the end of the portal. Thank you, and my apologies for being a bit above time. Thank you.
Your passion is inspiring, and it really emphasizes how important it is that we engage all of society, that we engage the private sector, the public sector, non-governmental organizations, communities, and workers' rights organizations in this dialogue, because we cannot afford to lose a single health worker. We can't afford not to invest in creating more health workers, and we can't afford not to protect our health workers. With that said, I have one question for each of our panelists, and with the great delight that many of your interventions have highlighted elements that we have in the Human Resource for Health guidance, which I encourage everybody to take a look at. Many of you have also emphasized many of the really key points that we have within the International Year of Health and Care Workers. So I'll begin with, and I'll ask each panelist to mind the 2 minutes. I'm going to do this to remind you when you're just about done, to mind the 2-minute response time. So I know Dr. Sangai, you've already responded in the chat, but I'm just going to say, how was it that the small country of Bhutan was able to reallocate and smoothly reallocate its health workers in order to ensure that they could respond to this pandemic? What specifically was the big change for Bhutan?
So if I understand your question, how we are able to deploy the health workers from one health facility to other facility, right?
Yes, please.
Oh, yes. In fact, as I said in my presentation, that yes, initially we had tough time, like because initially we didn't have this approach, like kind of cluster approach was not there. So we had to personally call the chief medical officers of the health facilities, and we were asking them now how many they would be able to relieve or release their health personnel to the required facilities. So now, initially, yes, now since there was no plan, so we had to ask. And then, of course, we received directives from the management, in fact, from the health minister and the health secretary. So now see, I don't know whether you visited Bhutan. Now, the case, the first case was in Thimphu, and so we had to request the nearby hospitals or nearby health facility to send their people as per the requirement we submitted to them. And so one way, yes, we had to consult our chief medical officers, and in other way, so we got directives from the management or the health minister and the secretaries. So we were just out of, I think that was out of panic, or I don't know, out of urgency. We had difficult times when we went through difficult times, and for making deployment. So now, so that was initial. Now, so after from the second lockdown, so we were ready and we were able to develop a lot of guidelines, and also, as I said, a lot of SOPs for each professional. Suppose now for quarantine facilities, we had to develop a separate guideline for the, and for the isolation, we had to develop a separate. So these are some of the measures we were able to take, and otherwise now we are fairly comfortable to face if the third wave or the second wave comes, if we face this, the COVID outbreak. So there was a little bit of confusion initially. So the most important is that our health facilities or the chief medical officer were cooperative, and so as per the directives of the Ministry of Health, so they were able to provide us the requirement of health professionals. Thank you.
Thank you so much, sir. I have a question for Anissa. Is this an opportunity to mainstream psychological support and make it structural, make it part of working conditions for health workers, even beyond COVID-19?
Oui, bien sûr. C'est un problème, comme j'ai expliqué, c'était un problème chronique, c'est pas un problème nouveau. Et les interventions, il y a un problème de... Voilà, la vidéo a repris, je pense. Voilà. Donc, je disais que la prise en charge dans tout, en général, doit être pluridisciplinaire. Comme j'ai insisté sur ce côté, que voilà, pour la prise en charge psychologique, pour faire face à cet état d'épuisement mental du professionnel de la santé, il ne suffit pas de mobiliser des psychiatres et des psychologues. C'est toutes les conditions de travail qui doivent être adaptées. Et comme on dit, si justement mes collègues, les professionnels de la santé sont surutilisés, mais plus que cela, plus que l'épuisement, plus que le stress, il y a le manque de reconnaissance, que ce soit par rapport à la récompense financière, que ce soit aussi, vous avez parlé de, on applaudit les professionnels de la santé, ici, même pas toujours, sauf quand vraiment les gens ont vraiment peur et qu'ils sont directement concernés. Donc oui, il faut une intervention complète au niveau des professionnels de la santé qui ont des besoins particuliers, en particulier les femmes qui ont des enfants en bas âge, qui ont besoin, par exemple, il y a des hôpitaux où il y a des services de crèche pour les enfants et pour les personnes, voilà, il faut faire un effort pour faciliter, pour que le professionnel de la santé soit à l'aise quand il est dans son travail, pour qu'il puisse se consacrer complètement à son travail, et même après la crise. Ça n'a pas été fait avant la crise. Et la crise, c'était une occasion pour révéler toutes ces faiblesses, toute cette fragilité. Il faut qu'on retienne la leçon et il faut qu'on fasse plus attention, sinon on ne va plus trouver personne. Les gens sont en train de déserter le secteur de la santé parce que même il y a des études qui ont montré que les professionnels de la santé perdent des années de santé, perdent des années de leur vie en raison du stress qu'ils subissent dans leur travail.
Well, I couldn't have said that better. Thank you for that impassioned plea. I've got one question now for Monsieur Baba Ai. And how can we champion the rights of health workers lacking formal union representation, like from the migrant sector or informal sector health workers? Mr. Baba I, please.
Thank you. That's a very good question. PSI has been at the fore of championing the rights of migrant workers and also informal sector, in quote. I'll come to this very quickly. One, when we talk of unions, people at times might look at this as the institution. No, two things are the soul of what the union is: combinations of working people, and two, organizing. And these two are interrelated. And in fact, it is when unions lose that sense that they become maybe some bureaucracy distant from the worker. So for migrant workers, the international nature of a global trade union federation, which is what PSI is as the Global Trade Union Federation of Health and Care Workers, is of utmost significance. We have been able to establish linkages between unions in sending and receiving countries that have been able to play significant roles in helping to defend the rights and interests of migrant health and care workers in receiving countries. This has even gotten to some extent institutionalized bilateral labor agreements that have been tripartite, including the unions on both sides. A sharp one is, say, that between Germany and the Philippines. So, and part of what is also done in receiving countries is, there was a time we even had a project where you had a migrant health and care worker passport, where you could used to go and easily join the union. But so the thing is, it's about organizing, it's about combination. Now, on the informal sector, it's kind of tricky, because what you see with increasing precarious work in the sector is itself informalization of labor and employment relations in what had always been seen as the formal sector. But when you talk more of informal sector in the health, the community health workers are on the front line of that definition. But we have been able to help. They are self-organizing in several countries, particularly in South Asia, and they have been able to win several concessions there, including recognition as a union. The All Pakistan Female Lady Health Workers Association started as an informal body, fought and won first the right to be, no, before even that, the right to get not less than the national minimum wage as their remuneration. And then secondly, the recognition as union. We have also had, because now the issue of duty bearers, right bearers, I saw Thomas's question. In Mumbai, we have been able to organize for community health workers to be able to hold the municipality liable, and also waste workers as the duty bearers. So it's about organizing, it's about combination, and the Global Trade Union Federation, PSI, plays a key role in this, in supporting unions and health workers within countries and across countries.
Baba, thank you for that impassioned response. And it proves that you can ask questions at the end. Hat tip to Ann Keeling for that great question on gender. So while I'm giving just a few final notes, I'm going to put up a poll. We ask for you to give us your anonymized responses to this. Lastly, I would like to thank everybody who's been involved in successfully bringing this event, including Mr. Thinley, Dr. Boasker, Mr. Baba I, Director of Health Workforce, Jim Campbell, who has been very supportive of us overall and gave us his time to introduce this important topic. Dr. Giorgio Cometto, who is the co-author of the Human Resources for Health Guidance in COVID-19 and the leader of this action series. Ms. Sharad Agarwal, who has been in charge of the logistics and has chased everything absolutely without cease. Ms. Beatrice Wamutitu, who is really the cog that makes us all work. To our wonderful interpretation crew, who I think got a very good workout today, and to our IT staff who have made this work. Jim, I'm just going to turn it over to you for a brief minute for any last reflections that you have on this event and on moving forward in the International Year of Health and Care Workers.
Thank you, Catherine, and to echo the thanks to all the panelists and contributors participants for today. This is session 1 of a 3-part series on the emphasis to protect, but it's ongoing dialogue in the International Year of the Health and Care Workers. There are intergovernmental processes underway in preparation for the World Health Assembly, the G7, the G20, and many other regional economic fora this year. We recognize that decent work and investing in decent work will be absolutely critical to not only managing the pandemic, but delivering health services, delivering universal health coverage. The workforce worldwide has given of themselves in the last 15 months, and there is a legal obligation. There are international treaty obligations around the rights of workers that we have to protect and ensure that we do so together. I thank you all for participating, but please continue to support advocacy and particular action in every country to ensure the workforce is protected. Thank you very much.
Thank you, Jim. Today is International Hand Hygiene Day. Please feel free to wash your hands often and thoroughly. For the International Year of Health and Care Workers, we showed you the campaign website. Please get involved. Send us your questions at workplace2030@who.int, and look forward to seeing you at episode 2 on investment. We've already given you a preview of the gaps that are here. We're ready to protect. Let's move forward together. Thank you so much for your participation.
Thank you to IT.